Bismillahirrahmanirrahim. Today we are going to critically appraise a journal article. I am Dr. Alishba Chandio, PGR Community Medicine, under the kind supervision of Professor Dr. Saira Afzal. We will be using the consort checklist for our critical appraisal. This is the consort checklist. The title of the article is Randomized Controlled Trial of Sulforafane and Metabolite Discovery in Children with Autism Spectrum Disorder. This is the abstract background. Sulforafane and isothiocyanate in broccoli has potential benefits relevant to autism spectrum disorder through its effects on several metabolic and immunologic pathways. Methods: we conducted a 15-week randomized parallel double-blind placebo-controlled clinical trial with 15-week open-label treatment and 6-week no treatment extension in 57 children ages 3 to 12 years with ASD over 36 weeks. 28 were assigned sulforafane and 29 received placebo. Results: data from 22 children taking sulforafane and 23 on the placebo were analyzed. Treatment effects on the primary outcome measured, the Ohio Autism Clinical Impression Scale in the general level of autism, were not significant between the sulforafane and placebo groups at 7 and 15 weeks. The effect sizes on the Ohio Autism Clinical Impression Scale were non-statistically significant, but positive, suggesting a possible trend towards greater improvement in those on treatment with sulforafane. Both groups improved in all subscales when on sulforafane during the open label phase. Caregiver ratings on the secondary outcome measures significantly on the aberrant behavior checklist at 15 weeks, but not on the social responsiveness scale 2. Ratings on the ABC and the SRS2 improved with a non-randomized analysis of the length of exposure to sulforafane compared to the pre-treatment baseline. The sample size was limited to 45 children with ASD, and we did not impute the missing data. We were unable to document significant changes in clinical assessments. The clinical results were confounded by placebo effects during the open label phase. Conclusion: SF led to small yet non-statistically significant changes in the total and all subscale scores of the primary outcome measure, while for secondary outcome measures, caregivers' assessment of children taking sulforafane showed statistically significant improvements compared to those taking placebo on the aberrant behavior checklist, but not on the social responsiveness scale 2. Trial registration: the study was prospectively registered at the clinicaltrials.gov. Funding was provided by the US Department of Defense. Introduction: the clinical heterogeneity and genetic diversity in the autism spectrum disorder support approaches to treatment from the perspective of key biochemical pathways. Biomarkers within pathways of hypothetical importance in ASD suggest treatment approaches to ASD that are not directly linked to the gene targets may be beneficial. Sulforafane and isothiocyanate from broccoli is a multifunctional phytochemical that has several demonstrated benefits on cellular processes relevant to ASD. We previously reported consistent improvements on clinical measures in treatment of young men with ASD using a SF-rich preparation compared to placebo. Benefits persisted with continued treatment in a 3-year follow-up study. Positive clinical effects as well findings in the urinary metabolites were also reported in an open-label trial in children and young adults using the same glucoraphanin-rich extract of broccoli seeds with added myrosinase that we used in the study. This report describes the result of our 36-week randomized parallel double-blind placebo-controlled phase 2 clinical trial of oral GR, stable metabolic precursor of sulforafane, from a GR-rich extract of broccoli seeds and myrosinase, the enzyme that converts glucoraphanin to sulforafane, in 45 children with ASD ages 3 to 12 years. Our aims were to determine the effects of sulforafane on the social responsiveness and problem behavior in boys and girls with ASD, to assess its safety and tolerability, and to evaluate the cellular biomarkers that support hypothesized mechanism of action of sulforafane in ASD. Our aim was to assess the in vivo effects of sulforafane, which has been shown in cultured rat macrophages in vitro to attenuate the NF-κB pathway. Heat shock proteins were examined because they were upregulated by the sulforafane in vitro and are cytoprotective and responsive to fever, which has been found to ameliorate the symptoms in some children with ASD. Due to importance of cellular oxidative stress and mitochondrial function in ASD, we measured free, reduced, oxidized, and total glutathione to assess subjects' instant redox status in response to sulforafane and mitochondrial respiration in response to sulforafane. Methods: participants: children ages 3 to 12 years with ASD were recruited from UMass outpatient clinics, local and regional autism societies, and pediatricians, and 20% were self-referred. All visits, one screening and 5 subsequent visits over 36 weeks took place in the Clinical Research Center or Department of Pediatrics at the UMass Memorial Medical Center in the Worcestershire, MA. Screening assessments for eligibility. Criteria for inclusion were diagnosis of moderate to severe ASD ages 3 to 12 years and a parent or guardian for consent. For exclusion, seizure within 1 year, impaired renal hepatic thyroid function, current infection or treatment with antibiotics, medication that may modify the testing of ASD, and chronic medical disorders. Of the 62 children who qualified for the study on the initial screening, 5 were excluded because of misdiagnosed ASD or inability to participate. All screening tests for the eligibility were carried out by experienced examiner using the following measures to determine the diagnosis of ASD, along with individual features of cognition and behavior. The Autism Diagnostic Observation Schedule, second edition, was administered to confirm the diagnosis of autism. The Winland Adaptive Behavior Scale, second edition, was conducted with the participant's primary caregiver via a semi-structured interview to measure functioning and communication. Lighter R is a non-verbal test of intelligence and cognitive functions from ages 2 to 20 years. The Ohio Autism Clinical Impression Scale, our primary outcome measure, is an instrument for weighting the severity of symptoms in 10 categories, including the general level of autism, social interaction, aberrant, and repetitive behavior. The Social Responsiveness Scale, second edition, a secondary outcome measure, is a 65-item rating scale measuring deficits in social behaviors. The Aberrant Behavior Checklist, a secondary outcome measure, is a 58-item behavior rating scale used to measure behavior problems across 5 subskills. Outcome measures: for our primary outcome measure, we use the Ohio Autism Clinical Global Impression Scale, and for secondary outcome measures, caregivers completed the Social Responsiveness Scale 2 and the Aberrant Behavior Checklist ABC. Study design: after screening, 57 children were assigned by the research pharmacy, double-blinded and randomized. 1:1 to either treatment with sulforafane or identical placebo for 15 weeks, then open label treatment of all children with sulforafane from 16 to 30 weeks, followed by no treatment from 31 to 36 weeks, phase 3. 6 clinical visits were scheduled. Screening baseline time 0, 7, 15, 22, 30, and 36 weeks. Screening included ADOS, Winland and lighter scales, and the Ohio Autism Clinical Impression Scales. Participants were assessed by senior clinicians with physical examination at each visit, along with assessment using the Ohio Autism Clinical Impression Scale 1 at visits 2 through 6. Parents or consistent caregivers experienced with ASD completed the ABC and Social Responsiveness Scale 2 after all visits and returned them by mail. Blood and urine specimens were collected at each visit for routine clinical laboratory studies as well as biomarker analysis. Dosage and administration: we were unable to produce or obtain SF-rich preparation for the studies. We used commercially available crushable tablets containing broccoli seed and sprout extracts as a source of GR and active myrosinase enzyme. Tablets commercially produced by Macol were produced by Nutramax Laboratories. Placebo tablets, identical in size and similar in appearance to the active tablets, identical in size and similar in appearance to the active tablets, contained microcrystalline cellulose, red, yellow, and black coloring and magnesium stearate, and were produced by Dr. Stephen Hogg. Randomization was performed 1:1 sulforafane and placebo, and tablets were dispensed by the Investigational Drug Service at the UMass Memorial Medical Center. The participants, families, and caregivers, as well as all the research staff and monitors, were blinded to a group assignment throughout the trial. Unblinding of all the participants took place at the end of the trial, except for 2 participants. Interventions: SF was administered as GR-rich broccoli seed extract tablets containing myrosinase as described above in an approximate dosage equivalent to 1 μl body weight. Placebo tablets in equal number were used based on the body weight. The study drug was administered orally at approximately the same time once daily, preferably in the morning to avoid insomnia and avoid taking it with a heavy meal. Caregivers were requested to keep daily medication diaries. Statistical analysis: the Ohio Autism Clinical Impression Scale 1, Social Responsiveness Scale 2, and Aberrant Behavior Checklist total scores and subscale scores, along with all the biomarkers, were treated as continuous variables. For each of these outcomes, we reported descriptive analysis at each time point. ABC scales, lethargy, irritability, and stereotypy were square root transformed, and all fold changes of biomarkers were natural log transformed to fit a normal distribution assumption. For all the scales and biomarkers, means at each visit by intervention group took into consideration matched pairs. matched on sex and fever response. Paired t-tests were used to compare means of SF group versus placebo group changes from baseline at each visit. Mixed effect modeling was carried out to account for repeated measures of outcome measures on the social responsiveness scale 2 and ABC and their respective subscores. In these models, the fixed effects were treatment and time. 3 models were produced for each outcome measure to compare results between different time points. Biomarkers were evaluated for their association with sulforaphanine using the simple linear regression at each visit and were expressed as change from baseline. A non-parametric method, Wilcoxon rank test, was used to also compare 9 biomarkers across various categories of interest. Mitochondrial analysis was conducted using the PAWS Statistics 18 general linear module with a within factor repeated measure of time and between subject variable of active treatment with sulforaphanine and versus placebo and developmental regression. This is a table showing baseline demographic and clinical characteristics for each group. This is the chart that shows the randomization and follow-up sulforaphanine and placebo groups. 62 children were screened initially, then 57 children underwent randomization, 5 excluded, no ASD diagnosed or could not participate. Then 26 were assigned to receive the sulforaphanine and 29 were assigned to receive the placebo. Then it is mentioned that 6 were included due to the following reasons. 22 were eligible, 22 were eligible for analysis in placebo. 45 children received sulforaphanine for up to 15 weeks. 5 were dropped out and the reasons are given. 40 children received no treatment after 30 weeks. 37 children returned for follow-up at 36 weeks. 18 parents returned the ABC and SRS2 scales. Results: 62 children who qualified for the study on the initial screening, 5 were excluded because of misdiagnosed ASD or inability to participate. 57 children were randomized, after which 12 did not complete 15 weeks of treatment in phase 1. 4 were excluded due to inability to take medication or illness and did not start the study. 8 due to adverse behaviors, non-compliance or insomnia and were lost to follow-up. Thus, data from a total of 45 children were used for most statistical analysis. Data from 22 children taking SF and 23 on the PL were analyzed. Treatment effects on the primary outcome measure, the Ohio Autism Clinical Impression Scale in the general level of autism, were not significant between SF and PL groups at 7 and 15 weeks. The effect sizes on the Ohio Autism Clinical Impression Scale were non-statistically significant but positive, suggesting a possible trend towards greater improvement in those on treatment with SF. Both groups improved in all subscales when on SF during the open label phase. Ratings on the ABC and SRS2 improved with a non-randomized analysis of the length of exposure to SF compared to the pre-treatment baseline. There were significant changes with SF compared to PL in biomarkers of glutathione redox status, mitochondrial respiration, inflammatory markers, and heat shock proteins. Clinical laboratory studies confirmed product safety. SF was very well tolerated and side effects of treatment, non-serious, included rare insomnia, irritability, and intolerance of taste and smell. This is the Ohio Autism Clinical Impression Scale 1 scores mean unit change from baseline at each visit. As it is shown, they have applied the paired t-test matched for sex and fever response in this table. Next is the social responsiveness scale 2. MANOVA test is used for the repeated measures and the aberrant behavior checklist length of exposure analysis. MANOVA is also used for this. Relation between respiratory parameters and both treatment with sulforaphanine and change in aberrant behavior checklist. In figure A, ATP-linked respiration significantly increased with SF treatment. B, individuals with developmental regression demonstrated a trend for decreased ATP-linked respiration. In figure C, greater improvement in ABC scores was associated with a greater increase in ATP-linked respiration. And in figure D, decrease in proton leak respiration across the entire study period. Discussion. Sulforaphanine has meaningful potential for treating children with ASD due to its many known mechanistic effects, clinical benefits, and lack of toxicity. Biomarkers provide strong evidence for the biological effects of SF, especially with respect to the markers of glutathione redox status, inflammatory cytokines, and mitochondrial function. The cytokines as measured in the serum are usually elevated in children with ASD, but were decreased on treatment with ASF, the most consistent change was in tumor necrosis factor A, increase in which have been frequently associated with ASD both in serum and cerebrospinal fluid. Mitochondrial function improved in the SF group as compared to the placebo group during the placebo control phase of the study, and improvement in the mitochondrial parameters correlated with improvements on the ABC scale. This suggests that the clinical response to SF was associated with changes in mitochondrial function, and that large intra-subject variability in the study was linked to the underlying biological responses. We found that SF was safe, but based upon the Ohio Autism Clinical Impression Scale, our primary clinical outcome measures effects were not significant. Effect size estimate showed small improvements with SF, although not significant from the general level of autism on the Ohio Autism Clinical Impression Scale. There were significant improvements on one of the secondary measures, but not on the social responsiveness scale 2. Improvements in sociability and communication were observed on the social responsiveness scale 2, as well as irritability, stereotypy, hyperactivity, and inappropriate speech on the ABC with a non-randomized analysis of the length of exposure. SF also had significant positive effects on the oxidative stress, cytoprotective markers, and cytokines, as well as mitochondrial functions. These were promising findings that require further investigation of both the clinical effects and mechanism of action of SF. Limitations. All clinical trials in children with ASD have inherent limitations due to clinical heterogeneity, cyclic variability in behavior, sleep, feeding, and bowel function, and anxiety associated with adaptation to intervention itself, and necessary clinical visits. The study was no exception, and many of these factors limited to the statistical significance of our clinical assessments. Sample size was limited to 45, and we did not impute the missing data. Clinical effects of GR plus myrosinase as a source of SF were more difficult to ascertain in children than those in our previous trial of our SF-rich preparation in young men with ASD. Now we will be using the consort checklist for this article. Title and abstract. Identification as a randomized trial in the title. Yes, the title does mention the term randomized trial. The title is very clear and concise. A structured summary of trial design, methods, results, and conclusion. Yes, the abstract does provide a structured summary of the trial design, methods, results, and conclusion. Introduction. Scientific background has been explained. The study also explains its rationale. Aims to conduct the trial were mentioned. However, no specific objective was mentioned, which was time-bound or measurable. Methods. Participants. It mentions the methods of recruitment of the participants, mentions the settings and locations, gives the criteria for the inclusion and exclusion of participants, give different measures used for screening the participants. Outcomes. It gives us completely defined primary and secondary outcome measures, including how and when they were assessed. Trial design. Description of the trial design has been mentioned. The allocation ratio has been mentioned. The important changes after the trial commencement have been shown in the form of a flow diagram, such as exclusion criteria and dropped out participants with reasons. Interventions. The interventions for each group with sufficient details to allow for replication, including how and when they were administered. It mentions the blinding of participants, care provided, research staff, and monitors to group assignment throughout the trial, and also the unblinding of all the participants at the end of the trial. Sample size. The study does not describe how the initial sample size of the 62 children who qualified after the initial screening was achieved. Randomization. The study didn't describe any methods to generate the random allocation sequence. Sequence generation, types of randomization not mentioned, whether it was block, simple, covariate, stratified. It didn't mention any mechanism to implement the random allocation sequence to conceal the sequence until interventions were assigned. It didn't mention who generated the random allocation sequence, who enrolled the participants, who assigned the participants to intervention implementation. Statistical analysis. The study mentions these statistical methods used to compare groups for primary and secondary outcome. Results. The study shows number of participants who were randomly assigned, received intended treatment, and were analyzed for primary outcome. The study also shows losses and exclusions for each group. A flow diagram has been shown. Dates defining periods of recruitment and follow-up mentioned. The study showed for each group the number of participants included in the analysis. The results also show a table with baseline demographic and clinical characteristics for each group. The study shows for each primary and secondary outcome results for each group and the estimated effect size and its precision 95% confidence interval. Any side effects and harms are mentioned. Discussion. The study showed its limitations. It didn't mention the generalizability of its result. it did give us the interpretation of the result. The study was registered at the clinicaltrials.gov on September 28, 2015. Funding was provided by the US Department of Defense. Now we will be summarizing our key points from this appraisal. What were our strengths? Gives eligibility criteria of the participants, explain different screening measures, including primary, secondary outcome measures, gives important changes after trial commencement in the form of flow diagram, also mentions the dropouts, mentions blinding, gives the limitations of its study, good statistical analysis along with different tests to compare groups for primary and secondary outcome measures. Results for each group are shown in the form of tables for each primary and secondary outcome along with effect size and its precision, 95% confidence interval. Limitations, no specific objective mentioned, does not explain how the sample size was calculated, does not explain the process of randomizing the participants into the trial, like sequence generation, allocation, concealment, and implementation, does not mention the type of randomization done, whether it was block or stratified, does not mention the generalizability of its result, does not mention its strengths, does not address the performance bias between the groups during the study. Thank you, everyone.
Thank you very much, Dr. Alishba. Very nice presentation. The best thing is, number first, you have selected a randomized clinical control trial. Number second, you have shown the consort statement before presenting the research paper. The third important thing is you have elaborated the strengths very well. And this limitation slide, it was also very good. I would suggest all the presenters, you must have these two slides in the end, strengths and second is limitation, so that we can further discuss it. If you go to your slide that is about limitation, I must include few important points in it. The first important limitation, as you have already discussed, is about the study sample size. As no sample size has been calculated, so there are many question marks that how this number has been selected. Second important thing is about randomization. Third important thing is about matching. How can we know that both the groups, they are being matched? So this is again one of the limitation. Next important thing is the conflict of interest, as there are many pharmaceutical medicines that are available, and pharmaceutical industry is always supporting one medicine over the other. So we must know what are the different conflict of interest and who was providing the drug while they are being trialed for this randomized clinical control trial. Another important strength is that whenever we have a multi-center randomized clinical control trial, there is more strength of the study. Again, it is a single center randomized clinical control trial, but that is being done under UMass. So we must know why the other centers, but they are not being offered to participate in it. And it is one of the limitation. Next important thing is we know that all the children who are above 12 years of age, they can fill their assent form. However, the consent has to be taken from the legal guardian. In this study, the age range consisted of all those who are not able to give their own consent. So what were the bioethical considerations? Who were those who were contacted, and how the IRB approvals have been done? So these are few things that need further elaboration in the limitations. Dr. Alishba, would you like to tell us more about the bioethical considerations that have been mentioned in the study?
Ma'am, no bioethical considerations were mentioned. It was just the consent was taken from the parents.
Again, if the child is above 12, we know that assent form has also been signed, and the child should also be asked to participate in the study. And if they refused, it is not only the guardian or the parent that is giving the consent. Even they refused, they are not allowed to participate in the study. So it is one of a weakness in this study. So what was the conflict of interest with the pharmaceutical industry, and who was providing the drug?
Ma'am, it was mentioned that in this slide that Nutramax Laboratories provided the sulforafane drugs, and placebo was produced by the Dr. Stephen Hong, University of Maryland Department of Pharmacy.
Yes, and what was their conflict of interest statement? It is not mentioned,
It is
but
not mentioned.
these laboratories and industries, how they have supported this research, and would they have those permissions to provide the drug? Because if they are providing the drug, it means they have some interest in knowing the results of the drug and how those results were conveyed to them. We need further elaboration about this important bioethical aspect. Overall, it is a very good study and it has very important findings. And as far as the results and statistical analysis were concerned, there was paired sample t-test that is showing that the same group has been compared, and analysis is robust. Number third important thing is that in analysis, they have certain important considerations, so analysis part is very strong and it is very robust. However, the bioethical part, yes, there are many question marks in it, like conflict of interest, funding sources, and how the consents and assent forms have been obtained. Overall, it is a good presentation. Very nice, Dr. Alishba. Thank
Thank
you
you.
very much. Allah Hafiz.
Hafiz, thank you, ma'am. Anyone wants to like to add anything?
Thank you, Dr. Alishba. It's good. It's very good presentation. Thank you.
Thank you, Dr. Amber.
Allah
Thank you.
Hafiz.
Allah Hafiz.